Well, thank you, Emily, for that discussion of what NIH does from grants. I'd like Michael to come up and Floyd to come up, and the three of them sit up here. And it's your opportunity now to ask them questions. So I would encourage you to either get up at those microphones, or there's people out there in the audience will come around and, oh, here he is right there. Okay. So let's start. Let's do it.
Sebastian Wurster from MD Anderson Cancer Center. I would like to make a comment for the third speaker about another critical gap that I perceive in the extramural funding program, and that's about the transition from postdoc to junior faculty to independence for non-US residents. I think that's a critical gap because many international postdocs are recruited at the senior level when they are too senior for the K99 ROO. And then with the current processing times for permanent residency, there's a quite long gap where we are not eligible for KO1 and these type of mechanisms. So it's pretty hard to get to the prelims for the RO1 mechanism. So maybe that's something to assess in the future.
Is this on? Yeah, I guess it is. Yeah, thank you for that comment. It is true that the case that being a US citizen is often the requirement. I think it remains the requirement for an individual in order to be eligible. And we don't have a companion program for non-US citizens, which I think that the postdoc, I don't know data on the postdoc pool over time, but it seems like it may be increasingly people that are not citizens in the US. I think that at least that's just my casual observation. I don't have data on that. So that is a gap, I agree.
Other questions? John.
First of all, I'd like to thank the three speakers. Excellent presentations and really eye-opening for all your efforts and the need to do so. One thing I would like to talk about is, you mentioned, Dr. Erbelding, that fungi does not have to do a lot with the brain. That's why there is more money for the brain. But I really would like to correct this, because now we are starting to see through microbiome study and the microbiome that fungi plays a role not only in autism, also in Alzheimer. So I think I want not to only encourage the NIH and NIAID to take this into consideration. Also, tomorrow I'll be talking about it. I like the medical mycology community to start thinking how we can understand the relationship between the bacteriome and the microbiome, because I think this is an area which really dying to be addressed. So.
Yeah, thanks for that comment. I'm not sure what I said about the microbiome, but you're right. There is an interaction there that's probably very important to understand. But I'm not sure that I said anything that excluded.
Actually, just to reference that, there is a lot of funding for the brain, and fungi does not play there. So I just wanted to let people to know.
Oh, well, that would be National Institute of Aging that would draw those boundaries, but you may be right.
Questions? Here we come.
Thank you for this really great presentations. I have a question for Michael. We talk a lot about the salary gaps for ID and other specialties. We talk a lot about it, but what are we doing about it? Because it's just incredible that we are making less than general medicine at this point.
Yeah, it's a great question. I agreed. It seems like it has been long discussed. I guess I would say, from my vantage, I haven't personally been involved in these kinds of activities, but my sense, I'm not sure if this is universally held, but is that there has been a real increase in the sort of strength and emphasis on those advocacy efforts, at least on the ID Society side of things over the past arbitrarily 2 or 3 years than there had been previously. And I I don't know, I have a sense that there's some maybe incremental ground being gained, but I mean, the sort of disastrous reimbursements for infectious diseases compared to other specialties is a very unfortunate reality, I think, of our practice that I wish that I and colleagues had a good sort of approach to that, because it remains such a formidable barrier. I agree.
Yes.
Geeta Sivasubramanian. I'm ID Fellowship Program Director at UCSF Fresno. And this is regarding recruiting more IM residents towards ID Fellowship. And I notice in the last 5 to 6 years, there's a big shift in how residents look for their medical knowledge resources or even applying. And it seems like social media is playing a big role in this. And I know pockets of, some programs are very active on social media where others are not. Should we together as IDSA be channeling our resources more towards making ourselves visible on social media, and should programs be putting in more effort towards that?
Yeah, great question. I think that certainly cannot hurt. I think my sense of that is that at least from a Twitter perspective, ID programs are sort of like the general population at large. I have no data to substantiate this, but some people are very active on Twitter, are extremely effective educators and communicators, and can be a very sort of rich discourse that can take place from an education perspective on Twitter, including, I'm very confident, people who are here at this meeting are very effective in that space. And then there's sort of the flip side of the toxicity that can ensue from, in that kind of a forum, and the impact that can have on some folks and just some people choosing to opt out. So it's a very complex space. We actually, this is not germane to your question, this is tangentially related, but we had a fellow come through our program who was very interested in Twitter as an education platform and had a whole, project devoted to that, actually around understanding fungal biomarkers and trying to educate sort of the community at large about risk factors for invasive fungal infections, among other mycosis-related topics. And with sort of limited advertising outside of the study group, got tremendous reach in a short period of time with thousands of followers across dozens of countries. And so you make an outstanding point. I think the potential reach of social media platforms in this space is substantial, and continuing, this is Sama Nimatalahi, who's at Arizona now. I think he and others continue to think innovatively about the use of that space, and I think that that's a really important avenue to travel. Agree. Thank you for that question.
Hi, Dimitris Kontogiannis from MD Anderson Cancer Center. 2 points I would like to reflect on. One is, can we encourage infectious disease or medical mycology very early on in the curriculum of medical school? Studies have shown that people are influenced by role models, they see in students' rotation, and I don't think there is a systemic way of the real role models that have a clear influence in a young person to really hone a career very early on. We talk about residence and money, which is all very correct, but I think having a son who is a medical student now, I mean, it's a very packed curriculum and a lot of things are lost, and infectious disease is lost. And the second is, I was honored to mentor a very talented physician scientist who was MD, PhD in bioengineering. And this opened my mind about the richness of synergy of fields like bioengineering, infectious disease, that really gives a new whole dimension to how we define physician scientists, infectious disease. And I think that's another way of looking of innovation for the physician scientists come to the field. Not only critical care ID, clinical fellowship, but ed-med programs, things like that.
I might maybe I'll just comment about the first comment. You're absolutely correct. I mean, there are data to this effect that the quality of medical residents and subsequent fellows recalled understanding of the quality of their medical school microbiology experience impacts their subsequent decision-making in terms of pursuit of a career in ID. It also extends to the residency program level, so I think that's also another opportunity, right? Interns often are inundated, at least in my biased view, with critical care and so on experiences and not often intensive ID-related experiences, and that can also bias selection. So I think sort of early attention to these areas is essential, as you say.
I just wanted to add on to that. In many institutions there, well, I won't say many, but there's some institutions where there is a number of medical mycologists that are also offering the course at the undergraduate level. I could say at my previous institution, when I went and asked to do a medical mycology class, they said, well, first, you need to teach another class because we don't want you to teach that, they call it a boutique class. And that boutique class within 2 semesters had over 50 people in it and had a waiting list. And so I think, and many of those people did go on to medical school, and when I talked to them when they were in medical school, they said, I actually learned more medical mycology at the undergraduate level than I did in medical school, and they were happy for that. And they were looking forward to doing more things in medical mycology, looking for labs to actually do research in. So I think that even earlier we can introduce people into medical mycology.
Thank you. Jay Aram, Malenta. I agree, we do need mycologists. We need people to help with awareness, diagnostics, new targets, and new antifungals that are more effective. For Dr. Wormley and anyone, what do you have representatives from many industries here. What do you think our role could be?
Well, one thing that I like to see is I like to see more industry and whoever to accept students in internships where they can actually practice what they're learning in the classrooms. I like them to actually take steps to promote and facilitate diversity in the programs, not just people who have the contacts in order to do that, but also to go out to make sure that the programs are diverse, that they're bringing people into, because it's the world that we're living here. We all have to learn to be able to communicate properly with everyone in whatever that we do. So have those opportunities. Also, what industry can also do is also partner with graduate programs. One thing that we did in my previous institutions that we actually had people in industry serve as mentors and PIs for some of our graduate students, so they can kind of get that industry experience, and a lot of graduate students actually sought out those sort of relationships and training. So industry, corporations, research institutes that do not have an education piece in their portfolio can actually partner with institutions to actually draw in more researchers and more people in their training at the undergraduate level as well as at the graduate level. And therefore we can expand the people who are going into research, going to medical mycology or whatnot by doing it that way.
I have a particularly niche interest. Again, I mentioned at the beginning that I primarily identify as an educator, and I work with colleagues. There's incredible educators across the country who develop like these amazing educational programs that don't have substantial reach for a variety of reasons. There's not very many. I understand I understand that funding is a challenge in mycology. I don't mean to say that that's not the case, but that is also the case in education. It's hard to get grants for projects, and I think if there were, sort of like a multi-organizational support of like through unrestricted educational grants for it, to perhaps building on the social media comment, web-based or other social media-based otherwise education platforms to sort of increase the reach of like these dynamic educational opportunities that we have within infectious diseases. You just need that kind of sort of emphasis and gusto behind these great education ideas to reach people and then sort of build enthusiasm around how amazing and dynamic infectious diseases and mycology can be. That kind of support would be great.
One other component I want to add is the military also are very interested in individuals doing research, or also in IDs doing research in areas of infectious diseases, medical mycology, so on and so forth.
Thanks, John. Chris Modi from Calgary. So occasionally as part of my job, I get an opportunity to talk to high school students. And it strikes me that during the pandemic, there has been a tremendous increase in interest in infectious diseases of all types because of the pandemic. And yet we're not really seeing an increase, corresponding increase, when people are either looking at graduate studies or looking at a subspecialty career as an MD. So I would submit that maybe we're screwing it up. And I wonder how we're doing that and whether you have any thoughts about that.
Yeah, I wish we weren't. I guess I would say it was the first year after the pandemic, right? There was an increase in the number of a proportion of spots that were filled in a significant way that we had not seen previously. And so I and colleagues were optimistic that that was going to be the first of a trend that would continue. And then, as I mentioned, we didn't see that subsequently. So I think I don't know that it's a make or break year, but I mean, it'd be very interesting to see what the data look like this year and whether sort of last year was an anomaly and we're going to see continued increases into ID from medicine, or whether the anomalous year was the sort of first post-pandemic year and we're just going to be back to where we are. There was a corresponding, I think it's been called in some corners the Fauci bump of like people applying to medical school the first year after the pandemic, with significant increases in numbers in that perspective. So perhaps it'll be years, but following that cohort to see how that shakes out will be of interest moving forward.
But I guess I have a question for the Canadians. Well, the one Canadian. The level of indebtedness, I think, after medical school is kind of a U.S. thing because that's how people get through, for the most part, they get through their education. But in Canada, I think there's more public support for education in general. So do you see the same? I mean, if it's all money all the need, educational indebtedness and the need to make more of a salary to pay it off, if that's the biggest driver, then do we see in other countries where medical school is more supported publicly, do we see the same choices in subspecialty training?
Okay. So I guess I would say, so Canadians, when they graduate from medical school, almost certainly have less debt than Americans do. Okay? But when people are out in practice, the salaries, I think, are probably pretty close to what you presented, that ID physicians make significant, maybe not less than general internal medicine or endocrinology or geriatrics, but they certainly are one of the lowest disciplines in terms of salary. Now, almost all infectious disease consultants in Canada are part of an academic sphere. There's almost none that are in private practice. And so many of those are on alternate relationship plans or something like that. And so that drives the salary. It's not, so that the clinical income comes from that rather than a fee-for-service type of income. But I would say that ID is one of the lower ones.
But one thing, Chris, you mentioned about the high schools, and I think that if you look at the Department of Education in the U.S., I think it was like a 25% increase in the funding for TRIO programs, in which many of those programs go into the high schools to introduce them to colleges and to hopefully to increase the number of people from certain communities going to college and graduating in college. And I think that as at our different universities, we can participate in those recruitment activities, go for those dollars, and to bring them on our campuses, but also introduce them to research opportunities on our campus, working in the sciences, because most of those kids probably don't know anyone with an MD or a PhD, but us showing an interest in them and showing them they can do this and nurturing them, we can kind of get them through the process so that they can one day come out on the other end with that PhD or that MD.
Sorry. Elon Schwartz here from Duke, but previously University of Alberta up until a few months ago. So I can comment as for your question about whether Canadian programs are in the same situation, and they are. It's difficult for Canadian programs, Canadian ID programs to fill their spots. It is still driven in part by remuneration. I would say that the disparities between a cardiologist and an infectious disease doctor are much more narrow, but they're still fairly pronounced. And certainly the amount of indebtedness is far less after graduating medical school in Canada. So although those factors are muted, we're still having the same problems of competing and recruiting.
Thank you. Anybody else? Since some of the oh yeah, please.
Perspective from overseas. So, and in Germany, it's pretty easy to fill the positions for infectious diseases physicians, and the system is certainly supported. The universities are supported by the state, and you don't exit university because and with a great debt. And we see the opposite, that those fields where it's most difficult to find young doctors to interested in them is surgery, all the surgical fields. So it's just the opposite, I guess. And maybe they could do part-time US and part-time in Germany. A good mix.
Anybody else? Somebody coming?
John, here.
Oh, yeah, I'm sorry.
Yoav Golan from Tufts. I think that the discussion is good, and I think that we really have to touch the points that affect the decrease in attractiveness of infectious disease fellowships, and I think there are a few additional causes to that. Not only that we make less money, but we get less and less interaction with medical students. As you know, most medical schools don't offer a microbiology course anymore. It's part of the pathophysiology. And many of us who used to teach in medical school in the early years, microbiology, do not have the opportunity. And, you know, it's always a matter of relationship. It's a matter of exposure. No one go to mathematics if they've never been exposed to it. And the same with infectious diseases. And you have to start it really early because people get exposed to other subspecialties, and I think this is one critical point. Another critical point that I want to point to is the fact that the patient population that we care for as infectious diseases doctors is more and more challenging with the opioid epidemic and even with COVID. I mean, you would think that COVID would be a huge source for recruitment because everyone understands how important infectious diseases are, but people have developed COVID fatigue and they don't want to see additional COVID patients. And I know that part of that is embedded within our profession, but part of that could be dealt with in a better way. And I think that we have to do that in order to increase the attractiveness.
David.
Hi, David Denning from Manchester, ex-Stanford Fellow, but never with an R01. There are enormous opportunities in our area in global health, which have not been exploited, I think. The gaps in diagnostics, the gap in epidemiology, the gap in implementation science, the gap in clinical care, clinical management outside the wealthy countries is enormous. We have been documenting this in Africa, but it's true in Latin America and other countries. I don't think there's a Fogarty program for medical mycology. I don't think there ever has been one. I would really like to see NIAID focus on an international mycology, drawing in the enormous resources that you have in this country. Some of this room has some of the world's best people, and very few of them extend their reach beyond the shores of the US. Some do, absolutely do, but many don't. And what tends to happen is you take very good people and you turn them into basic scientists, very good clinical people, and they become basic scientists. What about turning them into educators abroad, diagnostic public health doctors with an international reach? This would be of enormous value to the world.
Thank you for that comment. I think you said NIAID, but it probably pertains to other people on the panel here too.
Well, first of all, I want to thank everybody for, oh, wait, no. There's one there.
I'll try to close up shop. My name is Carlos Asumsao. I'm a second-year fellow infectious disease at a new ID program in Kern County in Bakersfield. One of the counties in red on your map with an underrepresentation of ID physicians there. And I just thought I should offer a little bit of perspective as I was one of the statistics of, I think it was the 2021 year program. So the nice thing about, I'm actually a Canadian expat, about 10 years now. I've been out of Canada, went through a Caribbean IMG, and through that difficult process, and et cetera, met a lot of mentors at Bakersfield that raised interest in cocci. And through that, in an understudied disease and infection in an underserved area, found somewhat of a calling. And the reimbursements there, I'll admit, it's better than average because of the underserved area. And I just want to point out that perhaps the national data is getting colored by the averages. And if we drill down to county data, there might be more nuances there that we can draw on lessons. I don't have data, obviously I'm just drawing on my own personal experience, but I think drilling down at the county level might help drive some more ideas to recruit at the local level. Yeah, so thank you.
Great suggestion, thank you.
So anybody else? So I encourage you to do the Q&A. You've done it very well. We've gone over time, and in the back they got this sign kind of, oh, you're over. Okay, I know I'm over, but we got time. They're lucky here because I had each one of them, I had a question for them and stuff like that, and I think I'll just throw them away. But actually a lot of the stuff that was said today were some of the things that I was thinking about. We're never going to change the money aspects of these things. I think there's big concern in the training of physicians and stuff like that we do have some COVID problems. And we had, as was mentioned, we have problems with never seeing these students and stuff like that because hospitalists take care of the patients and train the medical students and stuff like that. I think that's up to us to actually figure that out. We won't figure out the money aspects well. I think from Floyd's standpoint, I was always interested in the fact that it's unbelievable passion in some of the undergraduate students that I have running into the lab. And so asking whether you could fund anything where you could fund undergraduate students who work in a research laboratory for their own time, and they could have times on the summers and stuff like that. You just can't believe that there's the passion there, but there needs to be some resources to direct it and allow these people to follow their mentors. And finally, for NIAID, these are tricky businesses and stuff. You talk about T32s and stuff like that, and yet I've got to pay a whole mess of money for that fellow that gets in a T32 because their salaries are so low that I'm paying almost half for that. And for a K award, it's great. It's great. But when the funding level's under 20, you can't even decide. When you get under 20, and that's the funny, you can't even decide really when you're a reviewer the difference between a 15 and a 25 or 30. You can't do it. So it's arbitrary and capricious in the scoring. We have to spend more money on our trainees and stuff like that. We won't have the legacy that we actually need. So I'm right at 10 minutes over. I want to thank our group here because I didn't know how this would happen because I think we were doing something completely different. But I think it's extraordinarily important, not just for mycology, but also for the fields of basic science and clinical science. And I think listening to all three of them, they tell you a very important story of how we have to push farther to bring the next generation around. And so I appreciate all three of them doing the presentation they did. I appreciate you asking the questions. And I'm going to finish right now because the people in the back are just stressed out that we're not going to get to dinner. And for you guys, that's kind of important. So dinner, we have a break. Actually, we have a break until 5:45. So at this stage, you got about 34 minutes. And if you can show up at the dinner place, we have both some in memoriam type situations where some of our our colleagues have passed away in the last couple of years, and Louis will talk about that. And then Pete will bring out a lot of the industry. He's going to talk about some of the exciting things that's going on with them. And so I thank you for the start of this thing. I thank the people that got up here and gave the presentation. I thank you for your questions. So see you at dinner.